this combined Asami Posi webinar. And we have a very famous personality with us, Dr. Anil Bhave, and from USA, and he will be speaking on how to maximize knee range of motion and strength in femoral lengthening and deformity correction. And with me today is the moderator is Dr. Sandeep Patwardhan. He is the secretary of Posi. And I also welcome Dr. Dhiren Ganjawala, Dr. Gopa Kumar, Dr. Mangal Parihar, Dr. Jitendra Bhatnagar, Dr. Professor N.K. Das, Dr. Milind Chaudhary, and Dr. Sona. Now, firstly, let me introduce Dr. Anil Bhave. Anil Bhave is the Clinical Director of Orthopedics and Rehabilitation and Wasserman Gate Laboratory and Chief of Strategy of Rehabilitation Engineering and Virtual Rehab at Mount Sinai Hospital. I had a few times opportunity to meet him during the Baltimore limb deformity course, where I've been 4 times there. And Dr. Bhave name, if you read the book, The Principles of Deformity Correction, at many chapters there is a reference to Dr. Bhave's work on physical therapy and rehabilitation. So I welcome you, Dr. Bhave, and it's a great pleasure from India to have you as a speaker. Welcome, Dr. Bhave. Dr. Bhave, can you hear me?
Yes.
Okay. And now I request Dr. Sandeep Patwardhan to please, introduce the other faculty. Dr. Sandeep.
Thank you, Dr. Manish. Hello, Dr. Anil Bhave. So nice to see you again. And we're all looking forward to your talk. With me is a panel of very senior Ilizarov surgeons from the country, most of which need really no introduction. Dr. Mangal Parihar, who's in Mumbai fighting Corona, as well as we have Dr. Milind Chaudhary from Ujjain, who's a senior Ilizarov surgeon. We have Professor Gopa Kumar, we have Professor Nilay Kanti Das from Kolkata, and we also have Dr. Sona Sharma Kolke, who is assistant professor of physiotherapy in Sancheti Institute, and she's been closely related with Dr. Bhave. So along with my president, Dr. Dhiren Ganjwala, and courtesy Ashok and Shamshul and Ravi, I welcome you all to
Can you hear me?
Yes, sir. We can go ahead.
Yeah. Dr. Bhave, you can go to your presentation.
Good evening to all. Thank you for introduction. And this is our institute in Baltimore, where we perform about 500 to 600 limb lengthening reconstruction surgeries every year. And I have been part of founding this institute in 2000 with Dr. Paley and Dr. Herzenberg. So today, my goal is to cover in my webinar things that I have learned from many people that came before me. I cannot name everybody that has taught me, but I will at least try to give you some idea. This presentation is based on evidence, and I have no financial conflict or benefit from this presentation. I cannot take all the credit for the results that we produce. This is my, I am the director, this is my orthopedic rehabilitation physical therapy team. And there are a lot of people here who have been with me for more than 10 years as therapists and managers. And I give all of them credit for all the results that I share with you here on. So my journey actually started in 1977 in KEM Hospital. I went to physical therapy school, and then after that, I went to All India Institute of Rehabilitation in Haji Ali in Mumbai. And that is my picture treating a pediatric patient with polio in 1981. And you can see I have a lot of hair then. I did have a lot of hair then. So that's my journey in India. And then in early 80s, I went to USA. And I first landed in Hospital for Joint Diseases in New York in late 80s. And we had a lecture by Professor Elizarov in late in 1989 or early 90s, I forget. And he was showing some amazing work. And I was lucky enough because he would come and do 10 to 12 surgeries every 3 months. And I was on that unit. And I used to actually see some of his patients. Not many, he didn't do that many cases. That changed my mind, the way I thought about range of motion or strength. He used to show some amazing stuff in his slides, and it was not easy to understand him because everything came through the interpreter, but his clinical results were absolutely fantastic. And we started seeing some of those in joint diseases. By chance, I met Dr. Paley in 1993. I was treating one of his early patients, and I met him. And he had seen the results we had given that patient, and he was very keen that I join him. So I was going from Manhattan, which was like the mecca of orthopedics, to this little place called Kernan Hospital in 93. And I wasn't sure I really wanted this job, but I went and attended a couple of clinics of Dr. Paley. And I was convinced that this is what I should do for the rest of my life. So that's what I did. I went and joined him and Herzenberg in 93, and I continue to work with Herzenberg now because Dr. Paley is now moved to West Palm Beach. But they were the greatest influence in the limb lengthening field on my life. And then in 2000, we did the Institute of Advanced Orthopedics in Sinai. I was one of the founding members. I set up the whole gait lab, the therapy department. We hired other additional doctors, and it's grown into something really big now in terms of institute and the papers we publish and the things we do. So what are the lessons I learned? The lessons I have learned are like this car here. This is an ambassador car, and this is an ambassador car. It looks the same. Only thing they changed is all these people that were young here became older. So the principles of management of a patient were very soundly explained by Elizarov in his book. If you read it carefully, the thought about the muscle, how much time or how much rate the muscle likes to be lengthened at versus the tendon or the myofascial tissue versus the nerve, and what should be done for that. Why did he do 6 hours of physical activity every day for his patients? Makes a lot of sense. And then the one article that actually is probably the classic in limb lengthening that everybody should read is the article that Dr. Paley wrote in 1990 on problems, obstacles, and complications of limb lengthening. And that probably, and he was young then, he had not done that many cases, but he captured the whole essence of how to manage soft tissues, how to reduce subluxation, how to prevent subluxation. It's all there in that book, very nicely given. And I have read it many times very carefully, and it's one of the best articles. So I had a flavor of Dr. Paley's vision. I worked with him alongside all the time, and we learned together a lot of things, but he's a visionary. And then same is Dr. Herzenberg, who I still work with even today after 25 years, 27 years. And he is a visionary in his own mind in a different way. They matched each other very well. We did a lot of great things during that period of time, and that knowledge has continued to grow with me, and that's what I want to share. So I cannot take all the credit for what we do in terms of success of knee range of motion and strength. One of the things is there is a lot of surgical wizardry that happens with this. This is one of the surgical wizardry. They started doing this in early 90s, looking at carefully at how to place those pins versus not the iliceral wires, but the pins to minimize injury to the quadriceps muscle and the iliotibial band. And we made sure that every patient had full knee range of motion on the table before they left. So there was no muscle impalement and there was no IT band catching up to the pin causing pain, because we learned from that. We had a few cases like that where they had to go back and resect the iliotibial band distally to make it better. So that was one of the things. The pin placement became a huge deal as we went from wires to more 5mm or 6mm pins, especially around the knee joint, but also around the hip joint. The other thing we learned was that we always had to use a hinge. Debbie Stetinsky in 1980s actually showed in dogs that if you applied a fixator across, but you didn't distract the joint, or you did not do the range of motion in the joint, then you had early degradation of articular cartilage due to compression of the articular cartilage that happens when you do limb lengthening. Why does it happen? Was her postulate was that the muscles that go across the knee joint, if you don't apply a hinge and distract it and do range of motion, which is I call motion is lotion, motion is medicine. So what she showed very elegantly in dogs was that we have to do hinged distraction with range of motion to preserve the articular cartilage. Because what you should never have is a result of femoral lengthening causing articular cartilage degeneration and early osteoarthritis and needing a total knee replacement. So that's a bad thing for the patient. So that drove both Dr. Paley and Dr. Herzenberg to put hinges very carefully. Well, we were always taught that the hinge placement is difficult in a iliceral frame because we have the knee joint is actually it's a J, it translates backwards. But then came the article by Ann Hollister that showed that for the first 75 degrees of range of motion, it's actually a single point. So then Ann Hollister's article, which I have shown the picture from her article here, showed that due to rotation and translation of the tibia in vivo, you actually have a single point for first 75 degrees of motion, and then you start translating a little bit more. So if you can maintain 75 degrees of range of motion through a careful hinge placement that allows for that range of motion, then you would probably have much better result, and preservation of the articular cartilage was something that we started doing in early 90s, and we continue to do it even today. So that's the hinge placement there, and that's the careful flexion range of motion. The other thing we learned, and this is all, we did this together, was to assess patient preoperatively and which patient needs a pre-surgical soft tissue release and which patient doesn't. So we started doing the Duncan Ely test, and we called it, if it was less than 90 degrees of Duncan Ely positive test, then the patient most likely would need a proximal rectus release so that they don't get tight later. We also learned one more thing, is that don't test the hamstrings in 90 degrees of flexion, because that is not a functional position. We don't flex 90 degrees of hip and extend our knee fully. Only sprinters do that. Normal people only extend it at 45 degrees because that's how we function. So we started examining those patients based on some of the other literature at 45 degrees of hip flexion. And if they were tight, then their hamstrings were lengthened before surgery distally. That was another thing that we learned. We also learned the value of gastrocnemius contracture for the knee. And we call it a reverse silver skull test. A normal silver skull test is when you dorsiflex the ankle, or when you extend the knee fully, you lose your dorsiflexion. What we said was, we are going to dorsiflex the ankle and see its effect on the knee. So let's say you need 10 degrees of dorsiflexion. You keep the knee flexed first, dorsiflex the ankle, and slowly, gradually extend the knee. If the knee cannot extend fully with dorsiflexion, then it's a positive reverse silver score test. So then we looked at the gastrocnemius as an additional component that causes knee flexion contraction. These strategies we not only used as pre-surgical planning, but also as therapeutic modalities. And I'll show some of those as we go through the slides. We also learned through the gait lab that when the knee is flexed, the quadriceps are significantly at a mechanical disadvantage. And you can see here, this is our gait lab inverse dynamics modeling that will show that as the knee flexes, the hamstrings have a mechanical advantage, unlike what you would think based on the Blix curve, but actually you have a quadriceps deficiency and mechanical disadvantage as the knee gets flexed. So flexion makes more flexion and inhibits the quadriceps more and more as we flex. And that was a problem that we wanted to fix. We published in recently, not recently, but a few years ago, published in Acta Scandinavia Orthopedica on our experience of 60 patients with femoral lengthening that we followed up for 5 years. And we did the range of motion as well as strength test. And what we saw is what is here, is that loss of range of motion is more commonly seen in congenital patients than in developmental and never happens in post-traumatic. So then why did we do that? Because we wanted to see whether we have to throw everybody the same amount of therapy. Is the therapy based on diagnosis criteria, amount of range of lengthening or percent lengthening? So what we found was the most important criteria for deciding who will lose range of motion based on this was congenital patients. And then who would lose the strength? The older people would lose the strength a lot more than the younger patients. So if the limb lengthening happens in younger patients and the therapy is done properly, then your chance of losing strength is much lesser as compared to an older patient. The older the patient, about 30, there was a significant loss of quadriceps strength. This is probably the only paper that has been ever done that has 60 patients that followed for 5 years and looking at their strength over time to see whether there was a change in their strength. We were able to get most of the people's strength back, except for our older folks. They lost about 12% strength. Now, is it a big deal to lose 12, 15, 20% of strength? And I feel so, and I'll show you why I feel so. The next paper that we did in 1990s looked at this is probably one of my proudest achievements. This was my first JBJS publication in 1998 or 99, where we looked at gait asymmetry with leg length difference and improvement in discrepancy or asymmetry with gait. And I don't want to go into details of gait, but that's how your abnormal gait is on the force plate with the forces like this versus a normal gait looks like that. And we were able to get most of the patients to be there. What was one of the take-home messages for me was, the lesson learned was disability caused by leg length difference is significantly lesser than the disability caused by pain, stiffness, and or weakness. So that drove me always drove me for 3 things. One is that I must maintain pain-free range of motion with adequate muscle strength for patients to have long-term outcome. That is something that I always drove for. And we always work towards that to get the strength back to as normal as possible, to get pain-free range of motion optimized as quickly as possible. And the technology keeps evolving with therapy as well as with fixation, from external fixation to internal fixation to extramedullary plates. And all those things keep changing and keeps getting better and better and better for patients. But the principles don't change. So that's a lesson learned for me. And I want to emphasize that many times, because a leg length difference causes less disability overall than caused by intractable pain, stiffness, and or weakness. So how much knee motion do we need? Well, for walking, we need about 65, 67 degrees. Climbing stairs, going up, you need 85, coming down 90, 95 degrees. tying shoes 90. So if you can achieve somewhere between 110 degrees of flexion, you are functional. And this is a striker slide that I borrowed. It shows total knee can provide all of that. But the point is, you need about 125 degrees of flexion always to do most of your activities of daily living, and that's what we need. This is a slide that I want you to focus on because this is important. If you look at the percent of maximal voluntary contraction that we use in gait cycle, every gait cycle, we use 45% of our abductor muscle every time we take a step. We use 40% of the MVC in moment every time we walk, and 90% of strength when we walk. So what this is telling you is that you need to optimize strength, and Jackie Perry, one of the great leaders of gait analysis, showed us this, that you need almost 4+ strength at least to walk some distance. So we need to be able to achieve that degree of strength, and we need to have that many motor units to recycle through this process. Because every step you take, you're using some degree of motor units. So then the other motor units have to come up. And if our surgery or our lack of therapy damages the muscle, patients may be able to walk in the clinic, but because they get fatigued, they may not be able to walk longer distances. So that's my point, is that optimization of strength, even for walking, is so important. And this is a take-home message that has always driven me. And then in running or jogging, even gets worse. You need a lot more strength for being more functional. Running and jogging takes 3 times more than what you need for walking. The other thing is, we have to look at muscles differently. We have to look at muscles, each muscle is different. So for example, here, for the same amount of change in length, a gastrocnemius produces a different degree of tension in the muscle versus a sartorius or semitendinosus. So every muscle, depending on its pennation, and Elizarov mentioned it in his book a long time ago, that depending on the muscle and the way the orientation of muscle fibers is to the tendon, the muscle's resistance to the soft tissue, to the lengthening or change in length will be different. So that's a very important concept of passive difference or passive change. So the types of contracture we see in the lack of knee range of motion are adaptive muscle shortening due to pain, scar tissue adhesions, periarticular remodeling, and chronic subluxation. Those are the ones that we worry about all the time. If you look at the skeletal muscle itself, you see that there's sarcomeres, there's contractile element, and then there's a dense connective tissue that is septum and covering of the muscle. And tendon is mostly collagen, and it's bundles of collagen, and that's how. So what is the resistance? So the dense connective tissue or series elastic tissue, I break it into simple components. We have a contractile element and a series elastic dense connective tissue element, which is ground substance, collagen fibers, and ground substance. The problem is not with the contractile component. And if you go back, the great article that never actually was published by Jim Aronson from Arkansas in 1970s, what he did is he lengthened a limb and then gradually resected fascia. First he did IT band, then he did some of the myofascial tissue. And what he saw was the resistance all came from that myofascial tissue. Contractile element is not a problem. So it's a myofascial tissue, intermuscular connective tissue, tendons, and intermuscular fibrosis is what resists the change in range of motion and length. So what are the mechanical properties? It's oriented to resist tension in the axis. It has stress-strain curve. It has stress relaxation, and it responds to increase in temperature. Very simple. In response to increase in temperature. What is the response? If you raise the temperature of the dense connective tissue by X amount of degrees, you actually have 10 to 15% elongation that you can achieve through physical therapy. So we always have believed that warm compress or hot compress or hot packs, we call it, moist heat, is what we should always use for a limb lengthening muscle, or use hydrotherapy pool, because that allows appropriate deformation of the dense connective tissue. Simple. What are the problem muscles? Gastrocnemius, we talked about, it causes knee flexion contracture, and then the other things are more for the tibia. And for the femur, it's rectus femoris, quad tendon with patella alta, hamstrings, tensor fascia, IT band, adductors, and hip flexors. Those are the problem issues. So we always do PT preparation, which is moist heat, pain medications, and soft tissue. Mobilization in PT word is called STM, which is basically mobilizing the soft tissues through manipulative therapy. Where are we finding the problems in the fibrosis model? I was lucky to be part of this JBJ's British publication on international consensus on fibrosis of the knee joint. We published that 4 years ago. And when we looked at all the literature of all the problems that happen in knees, infrapatellar fibrosis, medial and lateral parapatellar fibrosis, suprapatellar pouch fibrosis, patellar tendon shortening, posterior fibrosis, quadriceps muscle fibrosis, I have seen that. Vastus intermedius can get scarred down on the femur. You can actually have fibrous slits that grow into the periosteum of the femur that have to be taken down. So we've seen all of that. So a scar tissue looks like this. A scar tissue from a pin site looks like this. There's cross-linking of the collagen fiber. It's adherent to the skin and to the underlying tissue. It's always a problem. And I tell my patients a very simple thing. A scar tissue looks like that. A scar tissue is a spaghetti in a bowl, wet spaghetti in a bowl, that you try to lift it up with a chopstick, then the whole wad of that comes up. But if you have a scar tissue that is more aligned and more streamlined and not as wet, then you can actually pick one spaghetti at a time, and you can actually have better flexibility in a spaghetti that is not like this. So scar is like this, we need to get you here. So what can we do for that? Well, one of the therapy modalities that we believe in is using manual therapy, using instrumented mobilization. You can choose what instrument you want, whatever is comfortable in your hand. But if you apply a shear force gently, you can't be too aggressive with limb lengthening patients, but if you apply the shear force across, you do have a change in the scar tissue matrix, and you actually have better realignment of the scar tissue. And we use that for all our limb lengthening patients. For example, here, this is a orthofix fixator lengthening patient, and we are using this like a manual therapy tool over the quadricep muscle, going as close we can go to the pin sites, getting the scar tissue mobilized. That's one of the things we do. These are some of our early results that are coming out now that show a faster range of motion recovery, reduced range of motion loss, and full return to range of motion. One of my problems is insurance companies. One of my problems is amount of money that patients have to spend on physical therapy. And I always believe that if I can ever achieve this, I call it better, faster, and cheaper. Better meaning we have to do better than what we did before. We have to do it faster than we have been able to do. And we have to do it cheaper because it cannot be too expensive. So all three things are important to me to perform or to do. And these type of techniques help me do that. Getting better, faster, cheaper is what I mean. So how to get the best range of motion and function? You have to have focused, customized, hands-on approach initially for all our patients. Sending limb lengthening patient to a therapy that does what we call circuit training therapy is a bad thing. They must be hands-on therapists. At least I definitely feel that for all my orthopedic patients, but definitely for limb lengthening and deformity correction patients, you can't use this type of approach. It's bad for them. We use very careful approach. We believe in correct stabilization. We don't use our hands on the leg, we use it on the fixator. It's more stable than putting it on the legs. We mobilize the patella, and I'll show you the importance of that. But we are very careful with our hand placement and the way we perform physical therapy. One of the things that I learned early on also is the role of IT band. It's a nuisance. It causes a lot of nuisance for range of motion. It's a great stabilizer of the hip and knee stability in walking and running, but it also is a bad thing for the range of motion. Why? Because it also is a bad thing for the patella. And I'll show you what I mean by that. This is a bilateral femur lengthening very early on in my career with internal fixation that shows this prominence of IT band with a significant abduction contracture. You never see this in a unilateral case. You only see this like this when you have bilateral lengthening, because there is no way to compensate for the pelvis, because both limbs are being stretched and both the IT bands get tight. So you always see this as a problem in extension of the hip like this, where they cannot bring their legs close together. So we have seen that. So that's what the fascia lata iliotibial band looks like. It inserts, as you know, into the vastus lateralis, short head of biceps, gluteus medius, tensor fascia, gluteus maximus, all those muscles. If you do osteotomy here, you're definitely stretching some of these muscles. Well, fascia lata and IT band is non-vascularized, non-contractile, and it also has a slip that goes into the lateral retinaculum or into the superior pole of the patella. The tightness of this is always pulling the patella laterally, always pulling patella laterally and immobilizing the patella. So I am a firm believer that every patient in orthopedics that has a knee problem should get patellar mobilization. I'm very passionate about this. Why? Because our total excursion of the patella is 5 to 7 centimeters from flexion to extension. This video probably is not going to work. Okay, that's fine. And knee flexion is limited by lack of patellar inferior mobility, but also knee extension is limited by patella being able to go superiorly. So I believe that patellar mobilization has to be done early and often. We teach all our patients, mothers or patients, to do it. If you don't do patellar mobilization early enough, you can get infrapatellar or a peripatellar fibrosis that takes a long time to resolve. The other thing that I realized is that I looked up a biomechanics paper that showed that if you apply a screw to the patella and then anchor it into the femur bone in full extension of the knee, you can still get about 30 degrees of flexion range of motion, because the patella doesn't have to engage and the soft tissues can give that much motion. But if you want any more motion than that, the soft tissues don't allow it because the patella is locked. So getting more than 45 degrees of motion right away is critical for the success of the patient, because you don't want patellar fibrosis to occur early on. That's something that is very important to me, and I show this slide to all my therapists. I want you to do lateral to medial, medial to lateral, superiorly, inferior patellar mobilizations, superior mobilizations, and some medial mobilizations. The only mobilizations I never do is medial to lateral. It's not needed in 99.9% of cases. And I spend at least 5 minutes of my therapy time making sure that not only I get it done, but I make sure that the patients get it done. If the patella doesn't move, the knee joint doesn't move. I always say this to my therapist. I say, if you don't mobilize the patella when you're flexing the knee or extending the knee, you should not have a therapy license, because it's like the most important thing. Because all you do is, if you don't mobilize the patella when you are flexing the knee, you basically compress the patella down onto the femoral trochlea and cause more pain. In a non-total knee patient, in a regular patient, you cause more pain. You have more pain under the patella from doing this. So I believe in that range of motion. The next rule of limb lengthening was physical therapy alone in absence of prolonged stretching by static or dynamic splint is a waste of time and money. I believe in that. I believe that only therapy cannot achieve the results that we want to achieve. And who taught us this? Ilizarov taught us this very well. And we always, since I joined Dr. Paley, I never saw him not use a splint across. Some type of splint across proximally and distally, definitely distally, to control and keep the muscle under stretch is probably one of the most important things or take-home messages from here. We've done all kinds of splints. I don't want to show you too many, but this is one that where we have a cast here. It's removable cast, by the way. And then you can hinge it like this and use a Taylor spatial strut to just compress it to extend the knee. If the knee flexion contracture is too much, then you can use a strut in the posterior region to stretch the knee to get the full extension. So we've done both. We have done, especially in patients with fibular hemimelia, with nerve problems, sometimes you have to allow the knee flexion contracture to occur because of the nerve issues and then later on treat it. And that's one of the examples. This is actually a patient of Dr. Paley's where we said, we'll allow the lengthening to occur. Because of the peroneal nerve symptoms, we will not worry about the knee flexion extension now. But once the lengthening is finished, we will stretch it out. And he also had a peroneal nerve release. So you can achieve that. And this is a bar that goes across to stretch the knee with a hinge at the knee joint. In 2000, I developed all these simple braces. For lack of vanity, I didn't call it Bhave brace or anything. I just call it custom knee device. And it's basically a removable brace using a specialized casting material, and it's very cheap to make. The hinges are not that expensive, and the casting material is not expensive. And the bands we use are the regular elastic bands for both extension of the knee here, or we can use it to improve flexion of the knee here as shown here. So we've been doing this since 20 years now. We have a lot of publications on this that we have done. It needs a special casting material. People ask me this all the time. It's a Delta Cast conformable. It's a polyester with fiberglass. A fiberglass alone, you can't make a removable splint out of it. It will break. But if you add a polyester fiber to the fiberglass, then you can actually make the splints that can open and close. So you can use this very effectively. For us in the United States, this is very cheap to do compared to the splints or the braces that we have to order. So at our center, 100% of our limb lengthening patients will engage in some type of bracing at some point in their limb lengthening process. This is an innovative way. This is orthofix lengthening. You can even do it inside this space and put a cast on to stretch the knee, and it can be removable, and you can then get good results with it. This is a simpler method of getting flexion. This is a femur lengthening with quadplasty. I remember that, and this is just a traction used for flexion. Or you can make a brace like this with the band in the back to stretch it. And we have done courses on this. This is a case of fibular hemimelia, where the same thing can be done, where a knee flexion contracture has occurred, and we have gradually stretched it to get full extension of the knee. Nothing else is needed other than good splinting and some stretching by parents at home. I want to spend a little time with this slide because this is probably the most important reason why I do the splinting. If you look at the splinting protocols, you can see that a dynamic splint, which is a spring-loaded device, or a mechanical splint, produce about 2.6 to 10 Newton meters of force. A therapist can produce up to 50 Newton meters of force. So a lot more force by a therapist. But if you add the time you can spend in the splint versus the time the therapist can do, the total dose by a therapist is not even 10% of the total dose you get when you apply a splint for a longer period of time. So what we call is total end range time dose in Newton meters per week. So I call it, we are very famous for the multiplier paper, but this is a multiplier effect in a different way. is that you are taking the time and the force into consideration. And if you add that together, you see that you have a significant difference in how you manage the patient. Because not every patient needs to go to therapy every day for resolving contraction. You could add therapy strategically, but add splinting in addition to that to apply a stretch across a joint, and you can achieve even a faster, better, faster, and cheaper result by doing this type of therapies. And this is something that stayed with me from the day I read the article by Dr. Paley in Problems, Obstacles, Complications article in 1990. It never changed. And now all these researches are new researches, but they explain the same thing. If we apply a stretch for 6 to 8 hours per day, and you don't have to apply a lot of stretch, you can get almost 1000% better stretch over the joint than a therapist can ever apply. That's a publication that we did in orthopedics looking at internal femoral lengthening. We even took care of subluxations with it. If you are interested, you can read it. It's in Orthopedic Journal in 2015, looking at how to make the brace that I showed you and what the results were with the internal femoral lengthening. And we had contractions up to 90 degrees. We used to, in early 2000, there was a nail called ISKD that came out, and it couldn't be controlled. So some patients got really horrible contractures. That doesn't happen anymore. We have much better internal devices that take care of it. So I want to show you a case. This is a case from early 2000 where the ISKD nail, bilateral femur lengthening, went too fast. He had 5 centimeter lengthening that happened in less than 3 weeks. It was so bad that patient developed severe contractures, nerve problems with reflex sympathetic dystrophy, and we had to apply external fixator to his bilateral femurs to stop his lengthening. We couldn't treat him with therapy because he had reflex sympathetic dystrophy. You couldn't touch him. He couldn't wear clothes. It was that bad. His hip flexion contracture was 40 degrees, just positional. Knee flexion contraction was 55 degrees and mild subluxation. On top of all that, he had bad insurance, less money. We had to deal with that also. So if you see, that's how I got him. This is my early case, and you can even inside the stockinette, you can see subluxation slightly in his knees. And these are normal knees. These are not ACL deficient knees. These are normal ACL, PCL intact knees. And when I got him, he was walking like this. I'm going to slow it so you see. Now, some people would say, we could do lengthening on this. We could do surgery on this. We didn't. We decided to do bracing. So I learned a lot through this. The reverse silver score test became popular with this because he had a gastrocnemius tightness, positional tightness. He had knee flexion contractures, and we experimented a little bit with him, and we were able to get full range of motion with him within 3 months. So from that position, the day we started treating him, we were able to get full extension at the hips, full extension at the knee, decent dorsiflexion, a resolution of the popliteal angle. He still has a positive at 90, but not at 45. And so we were able to get a good result on him. And eventually he walked like this. Full extension at the knee. Played tennis. This guy, we have almost a 15-year follow-up on this guy now. He's an adult. He's married with 2 children. He used to play tennis. So not always you need surgery to fix these problems if you apply the principles that are very common and can be used very effectively in patients. The smallest brace I have made on a 2-year-old is about 7 inches, 8 inches, which is about 19 centimeters. And the longest I have made is for a 6 foot, 5 foot tall patient. He was not having lengthening. He had a knee injury and we were fixing him. So the brace is very adaptable. If you are doing serious lengthening work, it's a great savior for you and your therapist to learn. Some of the other principles is, we learned this, that you can't sit like this. There's a frame here. We got to put an elevation. So elevation, prone knee hangs, very important for us. Gastroc, simultaneous knee extension, gastroc stretch was important for us. We recognize that when we correct a deformity like this and extend it, we got to keep our ankle up and keep the knee straight because the gastrocnemius will get out. So even with tibia, you will have problems with the knee if you don't manage it well. We used either a static splint or a dynamic splint. This is an example of a spring-loaded splint that we used and we still use for some patients. We use simple bars like this, where you just put a bar, make a cast, same material, it's removable, so you can take it off and on, put a ring in it, and just put a bar across at night time so that the kid doesn't keep the knee bent all night long. When she's sleeping, it's very comfortable, you can use it. This goes back to 90s. This is a Heidelberg fixator. Mangal will know this fixator. He was around when we were using this. And doing the simple things like knee extension. We are a big believers of teaching patients and mothers and fathers how to do it. So what we do is we not only do the therapy, but we actually spend time videotaping the therapy sessions. So the patients can actually take it home and do it themselves. That's been a great biofeedback. Now with the new world of tele-rehab, it even gets better. But we have been doing for the last 25 years, or 20 years at least, videotaping the patients and showing them. This is the patient himself, inferior mobilization of the patella, at the same time he's flexing his knee. Patient is doing it himself. So yes, it can be done like this. This is a mother stretching hamstrings. This is a prone knee hang for the patient. Correct hand placement by the parent and the therapist to stretch the knee. Self-stretching with the patient, correct hand placement again. And the last thing is how to use sponges or compression wrap. What we realized a long time ago was that when we started using 6mm pins, what we realized was that the tracking of the 6mm pin with lengthening leaves a hole. And when patients start bending their knee or straightening their knee, as they go through it, they have a lot of pain and what I call the skin pin movement across the skin moving across the pin. So we started experimenting with that long time ago. And what we said is we are going to use the bandaging material and put it so tight that the skin is completely pushed against the bone. Once you do that, all the pain goes away. So the patients can then easily facilitate their range of motion. So putting the sponges or the wraps correctly tight enough is something that we always teach our patients to do. Those of you who apply fixators across the hip joint for arthrodiastasis, with the flesh being there, it's a very useful, but also for the distal femur, it's a very useful thing. Our current practice is less and less of external fixator and more of precise nails, so we don't have to do it as much. Some of the difficult cases, this is a previously osteomyelitis case, a resection of the bone, 8 centimeters, tough cases. This is a tough case. Even with good therapy, they can get range of motion problems. And this is one of my favorite techniques. I just want to show you that, where basically I'm applying a strap across myself and applying a distraction force at the same time having him extend his knee. So there are lots of little techniques that we teach our therapists, teach our other therapists to do it. The patellar tracking is very important, so we will use a lot of taping for the patellar tracking to get correct position of the patella, because any lateral subluxation of the patella as you're trying to achieve knee range of motion will cause compressive pain. So we got to make sure that the patella stays in the trochlea. So we will use that type of technique. What about muscle strength? We didn't talk about that yet. So we believe in muscle stimulation. Other than other exercise, of course, we do exercise. But one of the drawbacks of our surgery or of what happens to our patient is that if you, after surgery, if you keep the patient immobile and not keep moving right away with their muscles, you lose 35 to 40% of volume of the muscles, especially fast fiber, in the first 2 weeks. So, and the first 2 weeks is not as easy to get the patient. So we use passive modality like muscle stimulation, because I believe that there is a significant arthrogenic muscle inhibition that occurs in quadriceps muscle. It's a very complex neurogenic effect of inflammation, swelling, joint laxity, receptor damage that can cause inhibition of the quadriceps motor neuronal pool. And to bypass it, you got to stop it here by giving electrical stimulation, because voluntary contraction is difficult. Pain, joint diffusion are a big thing. In limb lengthening, tourniquet is not a big issue, and age is not an issue. The other thing, this is again one of our older patients with a supracondylar fracture that had a deformity correction with IM nail. And we learned this a while ago that quadricep lag is probably really bad like this, but even worse like this. Because if you can't extend the knee and your quads are weak, you're going to buckle all the time. So we've worked very hard to get that knee straight as much as possible and active using muscle stimulation. We will use muscle stimulation right away. Right after surgery, we will start using it. This is a 5-year-old with a muscle stimulator. I have used muscle stimulator on kids since 1995. We have never, ever, ever had a problem of shocking anybody's pins or anything. You just have to be careful where you don't place the electrode on the pin side or the pin. But we have used it very successfully in our patients. This is an example of tibial frame with electrical stimulation, very old stimulator. These are now available for like $10 on Amazon or $5 on Amazon. You could use some of these things, and you basically want to have strong contraction of the muscles in order to get that activation of the fast fiber. Fast fiber is a large diameter fiber. You want activation and recruitment of those fibers to do better. So we are now using new technology. This has been very helpful in our internal lengthening patients, where it's a Bluetooth controlled device with a stimulator here. It looks like that with the 3 pads on the quadricep muscle. This controls the stimulation device. This measures the knee range of motion. So we can actually, it produces strong contractions, very useful for limb lengthening patients, and also measures the knee range of motion, both flexion and extension. So this has been very useful for people who had surgery in January and December. We were able to monitor them through the COVID times using this type of devices with electrical stimulation. The last thing we are doing more often now than ever before is something that is very exciting. We don't do this during lengthening, but after lengthening, if they have quadricep deficit, we are using something called blood flow restriction therapy, where 80% occlusion of the arterial flow, 100% venous flow, and you can exercise at 20% of your maximum capacity and still get more than 100% recruitment and atrophy of the muscles. So basically, it's a tourniquet-driven device, it's Doppler controlled, and patients can start doing exercises right away as soon as their lengthening stops to recruit more fast-twitch muscle fiber or fiber. And the last thing we do is we always engage patients in what we call eccentrics. Now, 80% of our function is eccentric, not concentric. Concentric is when we shorten the muscle, like we are lifting weights. Eccentric is when we lengthen the muscle, but muscle is under strain. So it's called negatives in athletic world, but eccentrics recruit muscle fibers much faster, better than concentrics, and actually train the patient for functional use. So we'll use that very effectively for our patients. This is early on. We catch our knee flexion contractures very early on if they happen. This is an example of a prone knee hang test where we measure the heel height, and if they are tight, this is the easiest way to know how much they are, and we aggressively treat it. We go after it with CKD, with electrical stimulation, and we eventually get full extension. And our results are now getting faster and faster. So we are not treating the patient in the post consolidation phase. We are actually addressing this, so we reduce our total time in therapy because we are catching these early and treating them more prophylactically. And you can get results like that. This girl has full extension in walking, but needs a foot surgery, and she will have this after the COVID to get her foot fixed. So that's her case. What about the nerve? What about the nerve problem? Well, the nerve problem is intense. We have published on this on review of 800 cases, and peroneal nerve is always an issue. Most of the peroneal nerve symptoms are picked up in therapy because we are stretching them. And when you do knee extension stretches with dorsiflexion, you actually do this. This is a very nice graphic that Dr. Herzenberg created, where what it basically says is what is not to do and what to do when you have nerve symptoms. So this is a very useful handout that we give all the patients. The key is never to flex your hip and extend your knee fully. So that's a no-no. But if you want to flex the hip, then you should flex the knee. So simple things like that really educate the patients well and help the patients better. One of the early things in achondroplasia, but also in bilateral lengthenings, we realized, especially achondroplasia with the tightness of the foramen, is that the prone positioning for the patient really helps them. Sitting is bad for these patients when they are doing lengthening. So we provide them with this type of wedge and a pillow, and so that they are totally decompressed, their spine is extended or at least flat. So this is a very useful way to do prone positioning for patients, especially with bilateral femur tibial lengthenings in achondroplastic patients. We believe in this. We used to believe in this a lot more than we do now because we are doing more internals. But imagine this girl is about 100 pounds, and this total weight of 4 fixators is probably more than 30, 40 pounds. Imagine 1/3 of your body weight on your legs and you try to move. You can't move. So the water therapy has been a very useful adjunct. Chlorine level at 5. We do the water cultures every month, and we use this type of chair to get the patients in and out of wheelchair, and has been very helpful. We do less and less of this now because we use more and more of internal fixation. We use what we call anti-gravity treadmill for recruitment of muscles. This is controlled weight bearing, and I think before we do that, this is controlled weight bearing, and patients are in the kind of a bubble, and we can adjust the weight according to what we want. But I want to show you a very simple method of promoting weight bearing. This is a $10 scale, and we basically have the patients do what we call axial loading multiple times a day for them to gradually increase weight bearing. It doesn't cost anything, it's very cheap, but it's one of the most useful biofeedback tools for weight bearing for getting the patients to weight bear more. The last thing I want to address, and I think we have about 10 minutes to address, is the knee subluxation, which is dreaded. And in early 90s, Dr. Paley tried 4 patients and did not put a hinge across or a fixator across, and all 4 of them subluxed. This is a Ollier's disease patient. He was not even a congenital. This is a patient with ISKD lengthening. She had a previous super knee done, but still she subluxed because the forces of the muscle are far greater than what the ligament can control. And we learned a lot from these early cases, and we started treating them. This was one of the early signs we saw in patients with ISKD, where they started showing an early subluxation. So we have this in our protocol of therapy. Every patient that has limb lengthening, we check this. Why subluxation is so bad? Because then you're losing the joint geometry, you're causing abnormal pressure over the cartilage, and that is why it's a bad thing in my opinion. We have also seen what we call anterior subluxation in patients with tibia. Tibial, we have not seen many, but we have seen few where there's anterior subluxation because of the gastrocnemius being tight, and that causes anterior subluxation. We have seen both. So subluxation is caused by hamstring contracture, IT band, quad weakness, cruciate dysfunction or absence, abnormal joint geometry, quad weakness, abnormal scarring, and nerve irritation. One of the things, if you go back again to that article by Dr. Paley, there is a figure there that shows why knee extension matters. And it shows very elegantly that if you maintain the extension of the knee, you cannot sublux. It's only when you have a slight flexion that you start subluxing. So we have a zero tolerance for KFC, and for me the KFC is knee flexion contracture and not chicken. I don't eat chicken. The other thing that we came out of our paper in ACTA Scandinavia was a short limb doesn't matter whether you are congenital, developmental, or post-traumatic. For more than 1 year, if you walk with a shorter limb, you don't engage your quadriceps, and you have up to 50 to 60% weakness in your muscles, quadricep muscles especially, even without surgery. So you're starting with a leg that is significantly weaker, if you test it carefully, than what you have normally. So you're starting with a 50%, and then you lose certain strength as you go through. So the quadriceps muscle inhibition with a hamstring overpowering IT band causes a posterolateral subluxation of the tibia, and that's a very commonly seen. The quads get inhibited by 30 cc's of fluid in the joint. You have lost 50% of your strength. At 60 cc's, you can't even do a straight leg raise. So a little bit of effusion will cause a significant lack of quadriceps overpull and a hamstring overpull and a quadriceps lack of strength. What about ligaments? Well, there's a great paper that was done with pediatric orthopedics intent to tell that showed that in presence of fibular hemilia or CFD, congenital femoral deficiency, almost 100% of the patients, except one, had a dysfunctioning ACL and PCL. So these people don't have ACL, PCL. The other thing they don't have is joint geometry. Look at this joint geometry on a short limb versus the long limb. We have a slight valgus there, distal femoral valgus, but also has a joint geometry that is not same as his other side. And plus here. So there's no opposition by the joint geometry itself. So we have used this principle again. I showed you this. Total time at end range must exceed 8 to 10 hours for 24-hour period. So any patient for preventing and treating subluxation must have a splint worn for 8 to 10 hours for 24-hour period. And the range of motion will depend on duration of stretch, frequency of stretch, and intensity of stretch. So that's important. You can't allow patients to come like this. This is a funny slide, but she wore this for knee extension stretches. You can't do that. So patients have to be compliant. Very critical that patients are compliant. This is just a graphic example of why the subluxation occurs. That's another example of a slight subluxation. So obtaining the long lateral X-ray during lengthening becomes very critical for analysis, and clinically measuring the subluxation or a sag sign of the tibia becomes important. This is a case one, early subluxation, developed a 35-degree flexion contracture. I came up with a very simple thing. We made a brace like I showed you before, but we used two elastic straps, one to push the femur down, one to push the tibia up, with elastic stretch that applied the knee extension stretch. And believe me, if you control the joint and reduce the subluxation, there is less pain. Immediately she was able to tolerate therapy better. We were able to get, in 2 weeks' time, extension range of motion better. It continued to get better after 3 weeks, and eventually we had full resolution. This is after her removal of the fixator. This girl is now a full-fledged ER doctor. This is a 15-year-old case. I think 2005 we treated her. So you can achieve results like this with just proper splinting and therapy in most of the patients. One of the other things that I don't know if you guys notice is that when we apply a fixator and we stretch the joints and we even apply a tibial frame and we use a knee extension bar, you are able to control the joint subluxation. But there is something called residual tension in the soft tissue. So this is a Herzenberg case where as soon as we took the fixator off, she subluxed. She developed a flexion contracture, she subluxed. And we cannot really push these patients too hard. So he always uses now a flexible nail so we could actually treat her. And we treated this with just conservative management of splinting with the straps, with the quadriceps activation, good soft tissue mobilization with instrumental massage around the posterior aspect of the knee, patellar mobilization, and we were able to get full resolution of this patient. This is another case of lengthening again. This is early on, and I think this is 2006 case, where we had almost 60% subluxation, same treatment again, and we were able to get full resolution of our extension. So we were able to achieve this.
Anil, your sound is mute. We can't hear you.
Yeah, Anil, we can't hear you. The last couple of.
Dr. Bhave, can you hear us? Dr. Bhave?
Hello.
Dr. Bhave, you unmute yourself. Shamshul?
Sir.
Can you do that?
No, he has some problem from his end, sir. He has to do it himself. You can call him, sir.
We can't hear you, sir.
Sorry about that. Sorry. So if you don't reduce it, then you are going to have.
Go back a minute, Anil. Go back a minute, please. Thank you.
Okay.
Thank you.
Here, start here.
Yes, thank you.
Okay. So this is a case of subluxation that happened after removal. So this is a patient who lived in Kentucky, did follow-up through, coming and going every 2 weeks, did some therapy in Kentucky. And on removal, this is what we found. So we said we will try this using our principles of physical therapy that I've explained. So what did we do for him? Well, first thing is we have to stretch the hamstrings so that they don't cause more subluxation. You have to reduce the subluxation with traction, with application of force like this. And all my stretches for the knee joint are always with what we call in therapy, posterior anterior mobilization. Nobody should stretch knee joint with applying forces across the long lever. There should be stability at the joint itself, manipulating the joint as you stretch because you want that reduction in subluxation to occur. So that's one thing. Same thing here. My hand is now distracting and applying a force upwards. My second hand is producing the hand downwards. So based on that principle, I was even more creative. So I think some of you will like this. We made a short leg brace here. This is removable. And we made a cuff that is also removable. We used Elizarov parts. And if you notice, I put the hinge back here. The hinge is here. And I'm using the Taylor spatial struts to distract the joint. So by extending here, you're basically rotating the tibia and pulling the tibia up like this, doing the same maneuver that I'm doing here. So I did this for this patient. This was a great case. I loved this case. And without any surgery, you saw the picture. We'll go back and I'll show you the picture back here. That's the picture. Without any surgery, we did this. We did the therapy. This mother drove from Kentucky every Sunday to be treated by me once a week and go back and then treat herself with this splint to get this resolved. And I think I can show the picture. I think I can show him doing it himself. So he did this. This is a long time ago case. So we did that on this patient. And we were able to get him to stretch out fully, no surgery, never did surgery. And we were able to reduce his knee significantly enough, and then eventually get his knee fully extended. So this case taught me a lot. So then when we got into trouble next time and the patient was non-compliant, like some people are, we just put a short leg cast on and a thigh cuff. We did the same thing, and we applied the cross to stretch it. Again, the hinge was not at the knee joint, it was distal. And we pulled it up again. And every patient after that, we had a problem, we fixed it. Luckily, we don't get enough of these now. People are becoming more compliant. We are using more internal fixation. We are making our limb lengthening surgery better, faster, and cheaper so that we don't get into this. But if you ever get into these situations in a pickle like this, you can do this. And then based on that, I developed this brace, which is a pneumatic brace with a bladder here in the front of the femur, back of the tibia on the sides with the extension band to allow that stretch that we use in our difficult quadricepsoplasty patients, in our difficult precise lengthening patients, to help them walk, but also to maintain their joint geometry better. And I think I'm close to my time being done. I have 3 more minutes, so I'll just show you this case. This is a very challenging case, TAR syndrome. Her fingers are here, she has no upper limbs. Her right limb is completely fused. The knee is fused, and her knee had a very bad varus and a flexion. We were never going to achieve full flexion, full extension at her knee because she uses her lower limb for hygiene, because that's all she has. If you take the knee flexion away from her, she would have a lot of problems because she uses her leg for hygiene. So because she has no arms. So this was a tough case. So the varus was really bothering her. She had a dynamic varus of 30 degrees and it was really bothering her. So we did the corrective surgery. Dr. Standard, one of our doctors here now, who's taken over our Dr. Paley, who did the surgery. Well, we got into a lot of trouble with this because this was a very weak muscle. It got weaker. She had nerve complications, all that. So first time she tried to walk, this was a disaster. She has no hands. The knee is fused. So this is a case about muscle recruitment. So we said, you know what, we're going to accept the knee flexion. We are not going to extend the knee. We're not going to try and extend, but we got to recruit her muscles better. So we put her on a 4-hour muscle stimulation program. Put her in the pool therapy for augmentation. We used the brace for extension assist. And when with the brace, she was able to walk a little bit better, but this looks terrible. This is horrible. But this girl is unbelievable. This is a story of the true spirit of what it can be. So we got her to walk a little bit better, independently, not limping. And this girl is an amazing story. The muscle recruitment strategy that I have shown you before worked, where we were able to get her to walk much better with more sureness. She has a good step length, symmetrical step length gait. And eventually, this is what this girl did. So muscle recruitment is as important as getting the knee range of motion. So that's the picture. And eventually, I will go back. I told her, when she showed me this picture, I said, you just wore it, but you never really did the snowboarding. You just stood there. So she said, I'm going to send you video. So she next day sent me the video where she's doing a downhill with the ski board going down the board. And eventually she did the 5-kilometer race. You can see her coming up. She walked 5 kilometers with the brace on. So, you know, it can be a disaster sometimes, but if we can manage, it's not just about range of motion, it's also about the strength and how you activate your muscles. To me, she's the greatest thing we have done. So, you know, I learned my talk here about knee range of motion and strength. To me, it's, again, just in summary, a disability caused by leg length difference is far less significant than caused by pain, weakness, or stiffness. And we should all strive to achieve full function of the patients. And I'll stop screen sharing and I'll open it up for discussion. I see Milind has joined. A lot of people that I know from past have joined. So I would love to take their advice and thoughts also on what we do.
Thank you, Dr. Bhave, for such a beautiful presentation and very informative. Dr. Bhave, before I hand over to Dr. For the panel discussion, I have a question for you. What is your experience with Botox?
I think I showed a slide.
Yeah, you showed a slide, but
Yeah.
how often do you use it and what is your experience?
We are not routinely using Botox in our femur lengthening patients. We are not doing soft tissue releases on all our patients. And the reason was that some of these scar tissue, if you do the soft tissue releases early on, in 6 weeks' time, the scar is enough. So what is the best time to do it? So what Herzenberg does, and I'll tell you, it's a little bit different based on who is doing it. What Herzenberg does, and I have always admired him for thinking differently, is he does the Botox and soft tissue release if the patient is in trouble at removal, to enhance the recovery process of the patient. Because one of the things that is damaging to patient is prolonged therapy or prolonged disability after removal of the fixator. So he will do it only if there is a positive Ely test or positive hamstring at 45 degrees. He will do strategic lengthenings in congenital femur definitely, or fibular hemilia. But in developmentals or post-traumatic, we are not doing it as often. The use of Botox is very strategically used. And I'll explain a little bit better. If we see a patient that not only has range of motion deficit, but also is very intolerant of therapy, or is having a lot of pain, or is resistant to splinting, then we are using Botox simultaneous with soft tissue releases on those patients. And this was propagated by Dr. Kerr Graham from Australia, who said that just doing a release of the tendon doesn't quiet the muscle down. We have to reduce the spasm in the muscle. So if we are going to do a surgery to release the tendon or release the soft tissue, dense connective tissue, then to keep the muscle not getting into spasms and weakening it slightly may be a better way to manage contractures. So that's how we are using it. We are being very strategic. We are not using Botox rampantly like on every patient, no.
Okay, thank you. And I hand over to Dr. Dhiren. Dr. Dhiren?
Yes, please. Yeah.
And you take over the panel discussion, but Dr. Milind Chaudhary has few questions.
Yeah, exactly. So we start with the very important question of Milind. Yes, Milind.
Hi, Anil. It's a lovely talk. Thank you very much. Needed to know about the article written by Rob Rosbrook about...
Milind, sir, your volume is... Please manage your
audio.
We are not able to hear me.
Yeah, thanks, Anil. So lovely talk. This is about a paper written by Rob Rosbrook about limited quadriceps plastic during the lengthening. Your experience, please, and some recommendations in the midst of the lengthening procedure, limited quadriceps plastic.
We have never done it. In our center, we have never done it. I have a very bad experience with quadriceps plasty and limb lengthening patient.
Okay.
There are very few people that have attempted a quadriceps plasty simultaneous with femur lengthening.
Okay.
Very few people in the world who have done it. And I have actually treated all of those patients until 2009, because until then, Dr. Paley was with us, and I have treated few patients. It's one of the most difficult things to achieve, at least the way Dr. Paley does the quadriceps plasty, and do a simultaneous femur lengthening. I know a patient who I still talk to who did this. I know many patients who did this. I have a serious problem with that concept because I don't know how much strength return there is from a quadriceps plasty procedure, because nobody has ever measured it. And when I say strength, I don't mean I have a grade 3, I can do a knee extension. Quadricep function, as I don't know if you joined early in the beginning, but I showed you a slide that in walking you need 40 to 45% of your quads every step you take.
I saw that, yeah.
Yeah. So my problem is, and I know Rob very well. I've asked this question to him before, and I'll ask again here, is that show it to me that you can actually maintain the strength of the quadricep.
They were talking about a limited quadricep, limited, just a very tiny,
okay.
That's what it was about.
There's a great, if you are interested, there's a great paper by Scott Delp from Stanford, who showed that 1 centimeter lengthening of the tendon reduces the strength of the muscle by 50%.
50.
50. It's for the soleus muscle. So yes, I agree that if the patient is in trouble, but doing it routinely, I'm not so sure. And if you do it at the time of index procedure, are you scarring down enough? If you do it at the, so I like Herzenberg's approach, where he has done this. He has done this before in patients who are in trouble at the time of removal. To me, that makes more sense, to my personally. Now, I have to say this. Our therapy situation is a lot different than Rob's is. We have a very controlled therapy department, meaning that we see all our patients. We have follow-up with all our patients. We have a very busy therapy, active therapy department. So then the question is, for the Rob is, if he doesn't have a very active therapy department, is this a better way to do it? And maybe, I don't know. So I have asked this question before because you don't want to ever have an extension lag on patient because they will not walk right. You want to have them to at least have grade 4+ muscle strength. And we are talking of people, especially with limb lengthening now, today's limb lengthening of precise nail, you're talking of people wanting to engage in sports activities. And sports requires 3 times, 4 times the strength of the normal strength. You're talking of people who want to be very active. And I just feel that we need to be aware of what Dr. Janet Conway in our hospital has done those. She does it with arthroscope. So basically, she's not really doing a quadplasty. She's just cleaning the patella. Maurizio Catani did that all the time, where he would clean the undersurface of the patella, get patella. And we have done that many times in patients. But a quadplasty by name itself, and I'm not very familiar exactly the surgical technique that Rob uses, so pardon me.
I got it.
Yeah.
The next question is about the 4-segment lengthening in achondroplasia. We find that our children are having, you're familiar with our situation in India. It's not so easy for them to travel long distances to come for follow-up. And a 4-segment lengthening with this compulsory period of wheelchair existence and all that is, how difficult is it for the patients? And we've tried to stay away from that. It's really tough for the parents and for the child to handle all the 4 limbs at the same time. So just a few words, your comments please about the difficulties experienced in 4-segment.
We used to do 4-segment lengthening and we had similar difficulties as you've had if you use all external fixator.
Okay.
So our current strategy is to use precise nails for the femur and a tailor special frame for the tibia.
Okay.
And that's worked really well for most of our patients. Unlike many centers, we are not able to do 5 days a week of therapy anymore.
Okay.
We cannot. Our financial situation of our patients doesn't allow that anymore. So we are being very creative with home exercise program, videos, splinting, muscle stimulation, everything that we can do to enhance that we are doing. But our experience with this precise nail, with internal nail for the femurs and a tailor special frame for tibias, or doesn't have to be tailor special, I'm just saying that because that's the commonest one we use. External fixator has been very, very successful. The other thing that we have done is is always follow the rule. If the patient has, there's a drawer taught me this. There's something about 5 centimeters and femur lengthening. It's not about percent. It's not about this. It's 5 centimeters. At 5 centimeters, patients start getting trouble. So what we are doing is we are titrating their therapy more. So we are doing less therapy during the early phases where there is some slack in the achondroplast. Achondroplasts have a lot of slag in their tissue, so you don't need to throw them a lot of therapy. But then we bring them back strategically when they are in trouble at that 5 centimeter mark, both for the femur or tibia. And that's when we address it much harder. But with that strategy, we haven't had too much trouble. But doing the fixation for all 4, we had tough time with our patients. It was not easy.
So to extrapolate the 5 centimeter thing, it's the question about the percentage lengthening, which tends to make sense to understand how much the muscles and other soft tissues are going to be put to stretch. So do you believe that percentage lengthening is important? Or you don't believe that?
The only paper I can go by is my own paper. We published this in Acta Scandinavia Orthopedica on 60 femur lengthenings, and we monitored their range of motion and strength for 5 years. We published that about 3 years ago. And that's probably the only paper in the literature that I know of that monitored patients with femur lengthening for 5 years and published data on their strength, but also on their range. What mattered the most, if we did the multiple analysis, the ANOVA, what mattered most was the etiology. Etiology was the primary factor for loss of range of motion and strength. So we never had problem with any post-traumatics. They all recovered fine. We did not have much problem with developmentals. We had problems with congenitals, always did. And so congenital femur lengthening or a tibial lengthening is far difficult than other things. So again, our therapy is based on that as to which patient needs what. Like the post-traumatic lengthening will probably see us once a week or twice a week. A developmental maybe twice a week or 3 times depending on where he is in the lengthening. And the congenitals are the ones that are the difficult ones. And they are the ones that get very, if you remember a case I showed you with the foot problem that still needs corrected, that's a 6 centimeter lengthening. And all our problems started at 5 centimeters. So that magic number of 5 for the congenital is very, very critical in my opinion. And I'm not just going by my personal opinion. I saw this drawer saying this all the time when I was with him, and I have seen Herzenberg say the same thing. So there's something about congenitals and 5 centimeters. In achondroplasia, we are getting about 8, and then we are getting in a lot of trouble. 8 centimeters, about 8, 9, that's when we get in a lot of trouble with them. Stature lengthenings are probably the most difficult to predict. And I don't know if you're doing stature lengthening. Are you doing stature lengthenings in India with the internal nails?
Yeah. Not much using the fungal problem.
Yeah.
Okay. Because I was not believing in this, but I've been doing, a lot of my patients are doing yoga now, preoperatively. Serious yoga. And we have a few patients who have done yoga and, they can't afford, the stature lengthenings can't afford the therapy that they otherwise get. But we have had good success with them, maintaining their range of motion with bracing, some therapy. And I don't know, there's a value of doing, you get biased by literature and then you don't do certain things. And I never did too much of rehab or before surgery. But I think doing aggressive stretching 1 month, starting 1 month before surgery and having the flexibility probably has a lot of value definitely in the stature lengthenings. We're going to try and do it for our congenital femurs also now.
This is what we do, Anil. You have given a wonderful talk. I really appreciate it. And in fact, this
Jitendra!
Jitendra, in fact, I've been doing this yoga before any surgery, at least for 15 days or a month. And then we allow patient to go for anything. And we never have this much of the physiotherapy department with us, what you have shown. So, but our results are really good, with that.
Good. Excellent.
And one more question I wanted to know from you. do you have done anything for preservation of cartilage? Of the, when we are doing large amount of lengthening, or when we are doing large amount of congenital deformity correction and all, you guys try to correct the deformities mechanically, and then what happens with the cartilage? Do you have done any study of the cartilage?
We have long-term follow-ups on our achondroplasia patients that we are about to publish, which is a 20-year follow-up on their knee symptoms. We also have a paper coming out on HTOs with deformity correction with 15-year follow-ups. So yes, we have some, but we don't have large data pool because HTO was something that is not being done as routinely as it should be done. So we don't have large data pool of that. We do have large data pool of, well, let me go back. I don't remember a single case. I only remember one case that I know of, and I see almost all limb lengthening patients. Since I have been working since '93, that has had a total knee done. I only know one case so far. That was an early case who had a very horrible subluxation of the knee, and she's gone on to have a total knee done. But I don't have a single case of total knee replacement. So it's not a direct answer to your question whether we have studies that we have mapped our T2 weighted MRI for the cartilage. No, we don't have that. What we have is symptomatology or end result. And most of our HTOs, a lot of our HTOs have withstood 15 years or more. And our achondroplasts have never had a total knee done yet. So, it's not a answer that you're looking for, but it's an answer, clinical answer for what you're asking.
Thank you. Thank you.
Okay, now I request Dr. Sona to ask her questions. I'm sure that being a head of the Department of Physiotherapy, she will have a lot of questions related to that.
I'm not the head. I'm an associate professor at Sancheti College of Physiotherapy. So, and I've had the good fortune of having a month's fellowship observer fellowship under Dr. Bhave at Baltimore. And yes, coming back and trying to pass on some of the knowledge that I have kind of gained from him and trying to put it or implement it in Sancheti. So, sir, just the one question that, there have been gems of wisdom which have come throughout the talk, and, I've just been noting them down. And I had, of course, experiencing, sir treating and his whole faculty treating the therapists who have undergone the lengthening procedure. My few questions was, how soon after the postoperative period is this exercise routine started, and what is the duration of each session? And of course, I was going to ask you the frequency, but you have already answered that for the traumatic, it's about once or twice a week because you do not expect much complications in them as far as the knee ROM is concerned, and developmental is usually twice or thrice. And congenital would go to 4 times a week, sir? Or would
initially 3 times, and as they get further into lengthening, maybe 4 or 5 times. But those are the tough ones. Those are the most tough ones.
And how soon after?
Postoperatively, our protocol is very standard. Every patient, if the patient comes back to the patient room by 12, then the patients are mobilized the same day, same evening. They are sitting up in the chair and they may stand unless they are 4-segment lengthening. Then they don't stand, they go in the wheelchair. The therapy is immediate in the inpatient floor, but our patients are not staying more than 2 days. So they go home. If the surgery happens Monday, they go home Wednesday. Sometimes Thursday, depending on how they're doing. They are given a set of exercises that they all get, and we use an app called Health Loop where they have access to their exercises. Their first outpatient appointment is in 1 week from surgery, usually. If they are staying in Baltimore, it happens faster. The frequency, duration, the duration is always 45 minutes. It doesn't matter what the etiology is. The duration is approximately 30 to 45 minutes. We usually have a patient engage in something other than being seen by a therapist. So they may do a muscle stimulation session or something. So it's not always hands-on for 45 minutes. That's what our protocol is.
Thank you, sir.
Okay, Dr. Gopakumar, your microphone is mute, sir. Yeah.
Sir, thank you for the excellent lecture which you have given. I just want to ask you, have you got any techniques for preventing hip subluxations, especially when you are doing congenital lengthening in congenital?
Yes. Well, we worry about anybody who has proximal lengthening, because we know some of these are not, they don't have a perfect acetabular slopes to maintain it. One of the keys I learned from Dr. Tajian, I don't know if you know the name, many people may not know the name, is hip joint is best when it's in abduction, in flexion, and internal rotation. It's more in the socket. So we give an abduction pillow for every patient that has a mid-diaphyseal or a proximal lengthening, which are not that common. But if they are, then they will get an abduction pillow, and they will get good stretching with the adductor muscles, always, and a hip flexor stretching. Those are our current strategies. Now, in patients, this is where, if patient starts showing subluxation or shows some, the angle, I forget the name, the CE angle changes, then we will go in and Botox the adductor muscle at that point and continue stretching with them. So that's where, even for the knee subluxation, if you see that this occurring and patient is in spasm and is in pain, then we might go and do a biceps Botox and a release of the distal IT band in case it's needed. But usually we haven't done that many to counter most of the subluxations in my department are treated with good conservative management. But we have done Botox. But in the hip muscle, we have always done it. Even for the Perthes patients that we do a hip distractor, we will do a psoas Botox, iliopsoas Botox, using the ultrasound guided Botox or EMG guided Botox.
Thank you.
Okay, yeah. Now, Nilekant, it's your turn for the questions.
Dr. Das speaking. As pediatric orthopedic surgeon, very often we have to treat caudal regression syndrome. All of we know a patient with caudal regression syndrome has intractable flexion contracture of knees. And my question is how to manage it. Whatever modality I use, I'm not satisfied. So far functional recovery is concerned. So my question to Anil Bhave, how to manage?
That's a tough one. I don't have a great answer for you. What I learned long time ago biomechanically is to get them fully straight is a fool's errand. They're better off being slightly flexed or flexed about 30 degrees. They function better at 30 degrees of flexion than they function in full extension. What we also saw is that in trying to get them to extend fully at their knee, you may lose significant flexion and make them dysfunctional. We actually published on it a long time ago called Mechanical Distraction. Actually, it's a Herzenberg paper, Mechanical Distraction of the knee joint for knee flexion, intractable knee flexion contractures. And in that paper, what we showed is we just alter their total arc of motion from a flexion to more extended with less flexion. So I don't have a very good answer for you on this one. It's a tough topic. I don't know if David Feldman, who works with Dr. Paley, he does a lot of these and he has a lot of success. He does staged procedures for these patients. And we have done unilateral cases have done well with us. The bilateral cases that are extremely difficult, the best answer I can give you is leave them slightly flexed and don't try to extend fully, and make them more functional. And that's my best answer for you. I don't have a better answer than that.
Thank you.
Dr. Dhiren.
Yes.
Dr. Dhiren,
Yeah, please.
questions from the audience. Can we take them?
Yeah,
now?
sure. That's most important.
Yeah, and this is a question from Dr. Praful Herod, that what is the role of plaster in treating subluxations?
What's the role of?
What is the role of plasters in treating subluxations?
Meaning just putting a cast on?
Yeah, yeah. Do you use that?
Some people do it. Our center, we have always used the hinge. We want to make everything removable. We are very fearful of destroying the cartilage and flattening the femoral condyle in pediatric patient by applying too much force. So we have never used a long leg cast with pressure across the joint and keep it immobilized, because I truly believe motion is lotion. You have to keep the movement. If you don't keep the movement, and Debbie Statinsky, if you look at the literature, Statinsky is probably the best paper ever written in the dog model that showed that 2 weeks of compressing the joint in a lengthened dog hind limb led to 50% destruction of the articular cartilage. So putting a cast, a long leg cast on with that, we have never done it. We probably have tried it a long time ago, but we are not doing it, and we are not doing it to correct subluxation. We might use long leg cast to protect a patient if we are not using a flexible nail on the femur during femur lengthening, but we have never done it to reduce subluxation. That's never been the case.
Dr. Bhave, there is, from one audience, there are multiple questions related to each other. Can you hear me, Dr. Bhave?
Yes, I can hear you.
Sir, there are multiple questions related to each other. Now, what is the protocol for knee range of motion exercises with articulated fixator assisted lengthening? And the second part is that when it is started after surgery, and how much knee flexion is allowed? And is the joint kept in distraction? And what is your frequency of your therapy, either twice or thrice a day? And when is the tibial frame removed, after completion of lengthening or after consolidation of new bone, along with the removal of rest of the fixator? Should I repeat them, or?
I will start from the last question first.
Okay.
We assess our patient, it's not always me, but our center assesses the patient at the time of removal. If the patient's range of motion, especially extension, is not easily available, meaning that if you try to push the knee down and patient cannot extend the knee on its own, or you have to apply gentle pressure and you don't get the knee straight, they have to do stretching until their tibial frame comes off. So their tibial frame does not come off if they are tight in their hamstrings or if they cannot extend the knee fully. Number one. Number two, it's always distracted. I forget the number, but I think the teaching is 5 millimeters of distraction is applied when the fixator is put across the knee joint. All knee joints, we don't tolerate any flexion. So always full extension of the knee starts day 2 or day 1, whatever is possible. The flexion is to maximal tolerance. And when I say that, I mean, what I let them do is I have them sit in the bed and I put their leg on my leg and I hold it and I say, let's start bending together. And I let it bend as far as it can go. So most people will get anywhere between 55 and 75 degrees of flexion on the day 1. And if we've never had it, we used to have this problem long time ago where patients wouldn't have knee flexion range of motion day 1 or day 2. We've never had it now. We always get at least 45 degrees of flexion day 2, day 3, whatever. That's our goal. But that is achieved through good patellar mobilization and One of the things that you should tell your therapist, never to do passive range of motion on the patient right after surgery, ever. Because passive range of motion causes muscle spasm. You do what you call active flexion or active extension guided by a therapist. And what I mean by that is, when you have the patient sit at the edge of the table and bend the knee, you want them to activate their hamstrings and inhibit their quadriceps. That's a natural neurogenic inhibition so that they don't get spasms and they can actually bend the knee without pain. And same thing with extension. Make them extend, use their quadriceps and relax their hamstrings. If you do passive mobilization early after surgery, any surgery, it doesn't matter what surgery, you cause more problems, more pain, and that memory of pain from therapy, especially in children, lasts forever. They see a therapist, they don't want to go to them. So we've been very careful in telling these are simple things, but they change the outcome of the patient very rapidly. So we always say gentle, active assisted motion, followed by gentle overpressure and passive motion as patient tolerates it better. If that answers your question.
Now, what is your frequency of flexion therapy, twice or thrice a day?
No, just tricep. We do about 15 to 20 repetitions. We hold the stretch for about between 15 and 30 seconds. And we will do it once a day in therapy. And then once a day, patient's mother or father does it.
Dr. Dhiren, please take over.
Yeah, like I have a question. In a span of 30 years, you have seen or you have migrated from external fixator to internal fixation. That's intramedullary lengthening. So what change of complication you have seen?
Let me go back. We have not totally migrated to internal.
Partly, or majority.
Partly we have gone to internal because we are still limited by the diameter of the femur bone. So we'll be not able to do certain patients. The new techniques of implantable plate and will change that, but right now we are not there yet. The soft tissue complications, except for scarring from the pin site, are same. The response of the muscle to limb lengthening has been a little bit less robust because you are able to control it with less pain. So the internal lengthening has allowed less pain and faster recovery. And we showed that in our, if you remember, we wrote a paper on femur lengthening over nail. And we saw that just pure external fixator versus lengthening over nail was much faster recovery and less pain. And the internal lengthening is even better. The problem is, and we have seen this when we get referred from other centers, is that the external fixator surgeon has the ability to control the knee motion through a tibial frame and an extension rod. You have nothing in the internal. So you have to depend on good therapy, good bracing, and good management of the patient, because there is no choice. You cannot allow the knee flexion contracture to occur, because then if you're a congenital, you're going to sublux. And let me tell you, no amount of ligament reconstruction will stop a muscle from pulling the joint. I don't believe in that. If your muscle is abnormal, it's going to pull the joint. I mean, we have seen patients who get PCL reconstruction with a graft, that if they have horrible contracture occur, they can sublux. So muscle contracture itself. So that's my long-winded answer to your short question.
Right. Okay. Then in the initial part of your lecture, you mentioned about the moist heat. Now that is true in the case of USA, where the temperature is very cold.
Yeah.
Like in India, where temperature is around 40 degrees at most of the time, say 40 degrees centigrade. Is it applicable?
Well, we use it in summer, and in Baltimore we have 38-degree summers, 40-degree summers. Patients still like it. We use it. It's one of the most simplest things you can do is to apply moisture to the patient. They are relaxed, their muscles are relaxed, and their connective tissue is easy to manipulate. It makes it easier for patients, especially children. When you are doing therapy, you as surgeon see the patient twice a week for 15 minutes, maybe 30 minutes. I have to see that patient every day, or sometimes 3 times a week, 4 times a week. For me to make them relax and be confident in what I do, through whatever means, we use it. The other thing we use very commonly, which is not a good thing, but we do it anyway, is use of Nintendo and PlayStation in our therapy gyms. That's been very useful. The non-therapy things that have been very useful are the moist heat, which is part of therapy, Nintendo or PlayStation, the Wii board for weight bearing, the hydrotherapy pool, and the most important thing that, in my opinion, is being a family conference that we do with every patient. And videotape the physiotherapy session and give it to the patient's mother or father saying, this is what we want you to do. And when they come back for follow-up, not every patient that gets surgery in Baltimore gets all their therapy in Baltimore. So then what do we do with those patients is we'll bring them back every 2 weeks or 3 weeks. When they come for our doctors to see them, we'll bring them down to therapy and we'll check them, we'll modify their program. And so we are invested in our patient throughout the lengthening process and even after the consolidation process.
Okay, in middle of your lecture, you mentioned about the compliance of patient, like some patients are not cooperative. So do you try to evaluate patient preoperatively, their psychological part for the compliance, or like how they will respond to pain? Do you assess that?
We have a psychologist in the hospital, neuropsychologist. So if we feel that we need to, then we engage the neuropsychologist, number one. And number two, we don't do a lot of stature lengthenings, but we always encourage our stature lengthening patients to go through a full psych eval. Not everybody does it. We don't make it mandatory, but we recommend it. But we don't do significant stature lengthening, so I can't tell you that. Very few. We do less than 5 a year, so it's not really a big business for us.
But do you refuse a surgery based on the psychological assessment that this patient is not compliant, or like will have a lot of issues during treatment or the rehabilitation? Do you refuse any patient for that?
We have done that on CFD patients who we feel have social issues, either a single mother, abusive mother, social issues are there. We have recommended amputation for them.
Okay, right.
Yes, we have done that. In our center, we have actually done a lot of Van Ness rotation plasties. We do it a little differently, but we have done rotation plasties, and we have also recommended amputation for some of the fibular hemimelia patient with a Touré foot, with a bad family situation. Limb lengthening surgery is not good for bad family situation. It's a bad thing. So yes, we have recommended that. Not every patient requires limb lengthening, especially in that category.
Okay, thank you. Dr. Manish, now you can take over.
Yeah, Dr. Mangal Parihar.
Yes, Manish.
Is there any question for Dr. Bhave?
No, actually, for me, this was like a revision of when I did my fellowship, because Conan had just been set up at that time. And it just underlined the fact that a lot of technology may change, but the principles don't change. And a lot of what he showed was what I learned from him in terms of, the follow-up care of Elizarov. And I think, really speaking, what I kind of underline all the time is only 50% of our good results are the result of surgery. 50% of it is the therapy that the patients undergo. And I think he kind of, underlined that perfectly. Much of what he does over the years, we've learned from him, including the splintage, the anterior drawer while extending the knee, the mobilization of the patella. Some of it was not in practice when I did the fellowship, but we keep meeting Anil time to time, and those things also we've picked up, you know. And I absolutely underline what he said, that if one person's results are better than the other, oftentimes it is probably the importance that person gives to physiotherapy, in addition to all the surgical principles. But you know, despite good surgery, if you don't have good therapy, then you can land up with problem. And it's good that this talk is now available for us to share. You know, when patients go out of town and things like that, we can just direct them to this talk on YouTube, and they get an instant refresher course on what therapy, the importance of, and how to do therapy for patients undergoing limb lengthening. Thanks, Anil.
Dr. Shamshul.
Welcome.
Yes, sir. I have a question from two of my physiotherapists from Patna, sir. The first one is from Dr. Neha Singh. She went to course at Pune also under you. She asked that in custom-made devices, for how much time we should apply it, or it should be continuous, and also the time and duration for the device.
So I do, as you know, I do not just rehab for limb lengthening, but I also do other things, like ligament reconstruction, total knees. So for limb lengthening patient, the reason we apply longer duration CK custom knee device is because surgery is happening every day. The lengthening is happening every day. So there's a change in length of the muscle that needs to be done. And we know that muscle likes to lengthen, the connective tissue likes to lengthen at 0.3 to 0.2 millimeters a day, versus the bone likes to lengthen at 1 millimeter a day. That was shown by Elizarov long time ago. So in limb lengthening patient, we use the custom knee device for 6 to 8 hours per 24-hour period. In a total knee patient, we'll use it for an hour twice a day. It's totally different animal. So in a limb lengthening patient, we'll always use the custom knee device, extension device for improved extension. Start with 4, go to 6, maybe even 8 hours per 24 hours. There's a great paper in Journal of Hand Surgery called Total Time at End Range. Total time at end range. So what they are showing is that even a Dupuytren's contracture with proper pharmaceutical management, injection followed by splinting, shows early recovery because you are aligning the collagen and the scar tissue properly. So the total time at end range for limb lengthening for me is start with 4, go to 6 to 8 hours per day. Most of my patients use it at night time.
Okay, thank you, sir.
Can you elaborate on the splint you have designed, one?
Yeah.
Splint you have, yeah. Please elaborate on it with pets and all what you were talking about.
So
the splint I designed. What?
Yeah, please continue, sir.
The splint I designed. Sorry. Do you want me to explain?
Yeah, yeah. I want to explain the splint you designed, one. You were talking about that.
Yeah. So the splint I designed was a simple idea that came about in 2000 when we had a lot of difficulty getting the commercially available splints. So I don't know if you remember at Kernan, we had a guy named Ricky, the casket.
Yeah, I know.
He used to do patellar tendon bearing short leg cast with a hinge with a cuff, thigh cuff. And the philosophy was, if you used it, then you would have better protected weight bearing than you just did a long leg cast. You remember that?
Yeah, yeah.
So I took that idea and I say, I can now have the material that allows me to open and close a cast. Before 2000, there was no material that allowed you to open a fiberglass cast. So there's a company, used to be Johnson & Johnson, later on it was taken by BSN Medical, they sell in India. I have done workshops in India on this. So they sell in India this casting material. So it's basically two fibers of fiberglass and 1 layer of polyester. So that allows you to open and close the cast without breaking the cast.
Okay.
And you use about a 4-inch one layer on the tibia, one on the femur, and then you basically use hinges, which are, you can use any hinge, that you put inside the cast material, and then you use the anchors on the front of the tibia, front of the femur, and put a band across the knee. So the total cost to me in United States is about $25 to $30 to make one for the patient. So that is compared to that, if we had to go commercial, that would cost us $500 to $1,000. So for us, that is very important to make it, again, faster, better, cheaper. That's all. We have done, Jitendra, these casts have been so popular with all other conditions also. I get patients for ACL, total knees, everything. We do about 500 of these every year. So we have done more than 10,000 casts now. And we have taught a lot of people. I have done courses in Brazil, and I've done one in India. I did recently one in Pune. We didn't do the workshop on casting, but we showed how to do it. So it's very easily doable. The extension brace is the easiest one to do. The flexion requires a little bit more skill to do, but it can be done with proper training. Yeah.
If I add on to that, I had the good fortune of, helping make a cast in Baltimore, and as well as undergoing the training when he had taken a similar course in Ahmedabad conference. So if you remember. So basically I was requesting sir if he could kind of have that same cast making, the brace making workshop in Pune itself when he comes next. So because I guess I have used it even for elbow. One patient of mine who had, elbow flexion limitation, I have made a similar cast for the elbow joint, and it has worked wonderfully well. And we had used it for a knee patient also, but we are not getting the material as easily, yeah. So one thing would be to kind of have that BSN medical to kind of have it more readily available, the conformable cast. And it's not really a very tough thing to do. So if all physiotherapists or even your physiotherapist can learn this technique, I mean, it's something very easy to make and very doable, and the patient's compliance to it is quite great because you start slow. You start it with half an hour, twice a day, sir. That's how you usually progress. And you build on the time till it's 4 to 6 hours, and then you tell the patient to just do it overnight. And it works wonderfully well.
So just to add to that, the simplicity matters, Jitendra, for the patient. The simpler it is easier for patients to use. There's no explanation required. It's not complex, it's simple. So we have done for elbow, I have done for wrist, I have done for knee flexion extension, and for ankle dorsiflexion. And I'm working one on the hip now. I don't have it yet ready. Yeah, I'm working on the hip.
Great.
Okay, sir. Sir, I have a second question from Patna from Dr. Swati Kumari, physiotherapist. She is asking that in a case of a 10-year-old knee flexion contracture with otherwise normal knee, with extension like 15 degrees and flexion 15 to 80 degrees. So is it treatable, sir? And if yes, how?
So one of the lessons I have learned is if you as a therapist try to do both flexion and extension at the same time, you achieve nothing. You have to first work on extension and use your techniques of relaxing the hamstrings, iliotibial band stretching, bicep stretching, gastroc stretching, mobilization of the knee, using the braces to get the knee straighter. Because I believe in what is called captured patella syndrome. When the knee is flexed, the patella is captured. It doesn't move well. So I believe in getting the knee extension first, because if you try to do both in the same therapy session, you get nowhere. So I always treat my patients for knee extension, and as they improve their knee extension, I'll start working with flexion.
Thank you, sir.
Dr. Milind had a question. Dr. Milind? Dr. Milind, are you around?
Yeah, he's here, but he's, yeah.
Which one by with a nephew? Which material is?
Sir, please loud on your voice, sir.
What?
It's a very, very practical question. Would you remember the name of the casting material?
Yeah, it's made by BSN Medical.
Okay, all right.
And it's called Dynacast. Basically it's a polyester.
Okay.
Yeah, Dynacast.
Okay.
And I know for a fact that they sell it in India because they made it available for the workshop.
It is available in India, sir. It is available.
Any other
and
questions?
The hinges, Milind, the hinges you can make your own.
Yes, yes.
You don't need we are now 3D printing all our hinges.
Really? Very nice.
Yeah, because they're cheaper. It cost us $3 to print the hinges.
Wow.
Yeah, so we're using 3D printed hinges. But if you don't have that, you can go to a regular, I know I told Sona this in Pune, you go to a regular shop, a lathe shop, they can punch out those hinges in no time.
No, but any orthotist, these double hinges are what they put on standard braces. So those will be available off the shelf also.
Yeah, you can use those too. I mean, I once started, I used a Bledsoe hinge, the long leg brace hinge. Then I went to the orthotic hinge, and they were still expensive, so I went to the Smith & Nephew hinge, which was cheaper. And now we found even a better way of doing it. We 3D print all our hinges. It's so much easier. And if you have 3D printers, I will give you those 5. You can print them yourself. I can share the 5.
We can reuse the hinges.
If the metal hinges you can reuse. Metal hinges you can reuse. Yeah, sure. You can just take it. I use metal hinges. I used to take it out and reuse it again. Yeah, sure. You can do that.
So in fact, the metal hinges, the thing is that for the medial side of the knee, you have to kind of bend it slightly.
Yeah.
So basically, I had met a fabricator in Pune, and he was ready to give me the pre-bended also.
Yeah.
So, we can work on getting the concentric hinges, which get a little pre-bended for the medial side. And it's available more cheaply compared to...
Yeah. You should have no problem getting it.
Yeah.
I haven't done many wrists, but it's very good for wrist fractures too. I have done few. And you can make even an adult wrist, the distal radius, the Colles fracture. I have done few of them for the wrist also, but it's most effective in the knee because of the long lever arms. But elbow also you can do it.
Any other question for Dr. Bhave from the panelists? I think we are done. Dr. Milind, yes?
Yes, just last question. This is about your paper in the ACTA Orthopedia Scandinavica. Very interesting. So it's a little frightening to imagine that somebody who got 3 or 4 centimeters of shortening is not so disabled as by somebody with 3 or 4 centimeters of shortening is not so disabled as he would be if he developed, say, an ankle equinus contracture or weakness of the muscles or stiffness of the joint. So where do you think is the cutoff? So, and how careful, say, a 2 centimeter lengthening sometimes is needed along with the deformity correction. So how much you think they can run into a lot of difficulties with even 2 centimeters of lengthening?
If they are preoperatively stiff, like I showed you that case of the previously osteomyelitic patient who's had a horrible soft tissue and then gets a 4 centimeter lengthening and he gets into a lot of trouble. I have seen that myself. So if they are previously stiff, any lengthening, my opinion, is tough for a patient who has previous stiffness. If you are a developmental or a post-traumatic, but you have no previous stiffness, probably 2 centimeters makes no difference. Probably they recover like that easily. My worry is not, one of my things that I have always said this, and I've learned this over time, is the clinical examination of muscle strength is useless. It tells you nothing. Because you are examining the patient based on your strength. The resistance you apply, a Milind can apply, can be different than a therapist who is 100 pounds can apply. So what Milind's 5x5 is not that therapist 5x5 is. So the therapist says, oh, he has full strength, but the therapist is only 100 pounds weight and the patient is 250 pounds weight. So we have to use some degree, my frank opinion is, we have to standardize our strength measurements either with good functional tests. And they don't have to have sophisticated dynamometers every time. A handheld dynamometer is not that expensive, most people can have it. Or a good functional test. We do a lot of functional testing, like repeated chair rise test, or a 20-inch step test. So we have to create some model where we assess the patient across the board and not just say, oh, everybody is doing well, they have full strength. That is a problem in long run for our field, because if the patients are unhappy 1 year down the road, not doing sports or not doing something, then it would be difficult. That's all I'm saying.
Any other questions for Dr. Any other questions from the panelists?
Well, okay. I'm going to say thank you to all for joining. It must be late already in India.
We have to thank you, sir.
Thanks,
Yeah.
So great. It was
we have
great
to thank you.
Okay. All right. Bye-bye, everybody. Bye-bye.
1 minute, sir. I have to thank Dr. Milay.
Okay.
Thanks, Anil.
You're welcome.
Dr. Nilay Das, Dr. Gopa Kumar, Dr. Ganjawala, and Dr. Jitendra Bhatnagar, and Dr. Sona. And especially I have to thank Dr. Shamshul Huda, Dr. Ashok Sham, and Dr. Ravi Chauhan for the technical support they have given to us. So I thank everyone, and it was a great show with more than 2,000 plus audience.
Oh, nice.
Thank you.
You want to have me today? I'm having later.
Okay, Dr. Shamshul, can you stop the recording?
Thank you, sir.
Okay.
Okay.
This,
Thank you.
yeah,
Very informative lecture.
Thank you. Bye-bye.
Bye.
Wait, Dr. Bhave, we have to talk to you. Dr. Shamshul, we are off.
Yes, sir. Just.
Yes.
Dr.
Yes,
Bhave, we want your help. Actually,
Yes.
Dr. Shamshul is already in, trying to contact Dr. Harzenberg. If we could get get Dr. Harzenberg involved in some webinar for Asami and Posi, a combined
Yes, sir.
webinar like this.
That will be
Today,
great.
I had a talk with Michael
Have
Asai also.
you approached him? Have you approached him?
Sir, I
Yes.
have messaged Dr. Michael Asai twice, sir. He said he'll be talking, sir.
Okay. I'll mention. I'll definitely mention to him on Tuesday when
Just
I go
request
back.
him. We would be very happy to have a maybe one or maybe couple of webinars with Dr. Harzenberg and team.
Okay, I will mention it to him.
Please, we
Yes, sir.
need your help.
I will.
Thank you, sir. Thank you.
Okay, bye-bye, everybody.
Bye-bye.
Have